So this is just true. There's no book in the world that has patient-centered learning for medical students. So, when we say, what do we mean by patient-centered? Well, that's what Harrison's textbook of internal medicine is, right? That's what patient-centered means, is start with your patient. So when you say, well, who does that for medical students? The answer is, well, no one. That's why you have to come to this course. That's why we started this course. If I could just use someone else's book, it'd be way less effort for me. So literally, we're inventing it as we go. And that's really why all the people that have come to work with Medical School Companion have come, because all of us believe we have to change medicine from these subject memorizing to this patient-centered learning. Now, you guys all want to come to America to study and or live, which means you have to pass American exams. And you're going to have to pass 2 exams. You're going to have to pass the basic sciences exam, as you know, which is our step 1 exam. And then after your clinical rotations, you're going to have to pass the step 2 exam. And believe it or not, they're reasonably controversial in the United States, because everyone says, if I'm going to get scored on my step 1 exam, it makes me really anxious. And that interferes with my ability to learn medicine. And the medical schools have said, if all the students are doing is UWorld and first aid, we're not teaching medicine. And so this past week, this has gone to a pass-fail exam, but they didn't change step 2. So really, nothing changed for you guys. What mattered to you guys is a different question. Over the past 3 years, look what the people who do this exam did. They changed it from 324 to 280 questions. Now understand, this is a really good exam. I think the NBME people know more about medical exam teaching than any other group of people in the world. We teach thousands of students, and I get to speak to dozens of them that I've personally taught. And when I say to them, how did that exam go? They always tell me this one thing: it was fair. It was a fair exam. And when I say to them, well, what do you mean by fair? They say, everything was about an important disease or an important principle. And even the ones I didn't know, I recognize I should have. So why would such excellent people have fewer data points? Because obviously more data points is better. And it goes to this idea of, how do you write a multiple choice question? So every time you see that difference, you say to yourself, if I was going to write a multiple choice question, how do I ask different subject materials? And it looks like this. When you go to write, and I've authored lots of question banks, there are 3 standards of questions. There's what we call the factoid question, there's the clinical vignette, and then there's a case study. And as you learn and you start getting ready for the exams, you should think about that very, very closely. Because a factoid question is just what you think it is. It tests a fact. So, what is the capital of India? You know it or you don't. That's very straightforward, and there aren't a lot of those on the exam. By far and away, the commonest one you're going to see is a vignette. Now, most of these vignettes are very faithful clinical vignettes. So they're going to be real life situations in a nice, tight little form, and then they're going to ask you a clinical question about it. So in that sense, half your exam is going to be very straightforward. Here's a diabetic. Why is there albumin in the urine? Very straightforward stuff. It's the other 50% that's the challenge. So half of the exam is going to be straightforward, and half the exam is going to be much more complex. So when we say, what is the idea of a case study? A case study is something where you know everything about the patient. You know their family history, you know their functional inquiry, you know all the medications, you know things that happened in the past. And of course, what that means is they are long. The second thing that you're going to see out of these longer questions is they're going to ask theoretical questions. If I had compound X that interacted with a kinase, and that gave me factor Y, what would that do to the transcription factor? And so what you've got to recognize is, you've never seen the problem before. It's going to ask you, can you think abstractly? So if you go to first aid, and believe me, I like first aid, make sure you get the most up-to-date one. Don't go cheap on that. Get the most up-to-date one. It's actually a lot better. If you go all first aid, it's going to be great for the factoid simple vignettes. But all the rest of them down here, the harder 50%, these are not going to be straightforward. These are all going to be related to this expression. You have to be able to think like a doctor. And of course, doctors are patient-centered. Here's the danger that you run. Look how much this has changed. Even 5 years ago, if you had someone who wrote their step 1 exam and you said, what was the exam like? You'd say, well, I spent 2 years here in my basic sciences sitting in a desk, and then I had to get over this terrible wall called my step 1 exam. Well, thank God I've got past that, because now I go to patient care. Well, this is no longer a jump. This is the expression you're going to type out and you're going to put on your bathroom mirror. Clinical medicine is built on a foundation of basic medical sciences. So what that means is you've got to start up here with your patient and you've got to explain to me all the basic sciences that underpin our diagnosis and care. And so what that now means is if that is true of the exam, the step 1 in the exam is the equivalent of the step 2 exam. Students who write the step 2 exam tell me the best way to prepare for the step 2 exam is to study for the step 1 exam. So for you guys going forward, you can recognize this is just one body of knowledge. On this side in step 2, you'll have a little bit more clinical judgment. And then step 1 back here, you're going to have a little bit more basic sciences, but they're going to be feeding off the same database, which is this is how you study. Start with your patient and explain to me the basic sciences. Okay, what we're going to do now is we'll spend the next couple of hours just talking medicine, because it turns out the best way to get ready for the exam is to think like a doctor. Start with a patient and walk me through. And so what I want you to think about, and this is going to be actually kind of new, which is look at the ways we think like doctors. Look at the tools you have to be able to use. Because this is the story. If you talk about the old exam and the new exam, you've got to study differently. Back in the old days, if you knew more facts and you knew lots of detailed facts, you did better. You were rewarded on the exam. That is not true. The facts you need now are facts that you're going to need for patient care. Everyone comes to these courses going, please tell me the high yield facts. Well, all of you must have first aid. I mean, do all of you have first aid? First aid has gone like this. It was about this fat back in 2014 when I first looked at it. Now you look at it, it's this fat. Yeah, because it's all of medicine. Looking at first aid doesn't help you at all because it's all of medicine. So it's a perfectly good source to look up the list of things you've got to have heard of. It's not going to teach you medicine because there are no high yield facts. There certainly are high yield concepts. So if you come to America and say, what do all of the Americans die of? Americans die of cardiovascular. So I sure as heck would know a lot about atherosclerosis. We all die, we're all obese. So I sure as heck would know a lot about diabetes mellitus. So when you say, what are they going to ask me? They're going to ask you common diseases and rare diseases that teach important principles. But the whole idea is, what are the concepts related to, for example, insulin resistance and type 2 diabetes? It's not tricky. You've got to be able to think clinically. So when we come to the question stems, you're going to have not a lot of factoid. You'll have very few factoid questions. They're all going to be bona fide clinical vignettes, or they're going to be abstract concepts that look like research study, because they want you to say, can you think in biochemistry? So let's talk about then, if I want to be patient-centered, what are some of the different ways I have to start thinking about all this material that you've learned? Remember, patient-centered means we start with the patient. okay? So here's our first principle. Clinical medicine is built on the foundation of basic medical sciences. Okay, brave words, thanks for nothing. What does that mean? Well, we're going to show you, I call this completeness. Here at Medical School Companion, completeness of knowledge is an idea, and we're going to practice that a little bit today so that as you go forward in your coursework, you'll say, I've got to put this into a completeness line. We're going to talk about that. The second thing you've got to be able to do is clinical reasoning. Medicine has a very specific order when you start with the patient. It starts with a chief complaint, from which you do a differential diagnosis, and at the medical school level, that is by organ, not disease. Then you get to a family of diseases, and only then can you make your diagnosis. So we're going to practice that, and I'm going to show you how that works. Here's an idea that actually is quite challenging, is the idea of natural history. And natural history says, if we do nothing, what happens to our patient? And that's a very, very odd idea, because what this says is this: after you make a diagnosis, the next thing you're going to have to do is see your patient. And your patient is going to say, doctor, what does this mean to me? And what are we going to do about it? Well, you know, for you guys, many of you are not yet actually treating patients. You sort of get to your diagnosis and you quit. But the exam is about patient-centered learning. So you're going to get lots of questions that say, how would you explain this to your patient, given that the average patient in America reads at a grade 5 level? So every time we talk about a disease, you have to be able to explain it to me in medical terms, but also in your mind's eye, ask yourself, how would I explain this to my mother's best friend? Because the questions on the exam can be quite very vernacular English. And then the last thing, which is how we're going to unite all of your pathology and your physiology, is you've got to understand the human body as a machine. It is bioengineered. Okay, 8% of African Americans have it in America. So it's a pretty common disease for us. Okay, what's the DNA defect? Oh, that's a protein. Okay, right off the start, this is chromosome 11. And I'm on the gene is my HB for hemoglobin and B for globin. And when you ask what the defect is, and in that gene, I have a codon, GAG, gets a single nucleotide polymorphism, that is a GTG. Now that's knowing your disease at the DNA level. And yes, they're going to ask you if it's important to the principle of the disease. Okay, now I can say, what do I see in the protein? Now you guys can talk about the protein. And watch what I'm going to do to draw the protein. This is what the protein, of course, is going to be beta globulin. And I'm going to draw it for you. What you're going to learn from me is everything should be in your mind's eye. If you can't draw it, you don't know it. Words don't stick. This is what it looks like. And then this is back. And then there's the tail. So right here, that's my heme pocket right there. And right here, there's the 6th position. And so that's going to go from a glutamic acid to a valine. Okay, so what? What happens? Why should I care? Why does it matter to your patient? Because we're not learning anything that doesn't help me in patient care. So that what that says is, anytime I decrease the oxygen, it's going to polymerize. And the reason is, this goes from polar, which repels all those tails, it goes to neutral, because valine is a neutral amino acid. And so what it means is, it means all of my betas, because it's a neutral tail, they can all join together. And we recognize that because when we look at the cell, all those polymers stretch out the cell, so that's our standard sickle. Anytime we have decreased oxygen, it's going to sickle, right? So what? Is sickling a problem? Oh, yes, that's true, Solani, but not because they stickled. It's not because they're a bad shape. It's not related to their oxygen carrying capacity. What happens is when they sickle, it upregulates all of the surface proteins on the red cell, and it makes them sticky, and it makes them sticky to the vessel. So just like you see ICAMs and integrins and all those proteins that you see in neutrophils, well, lots of cells can upregulate sticky proteins. And so the disease is not the sickling, the disease is the stickiness. And so the stickiness is what is going to give you microvascular occlusion. So there's the magic phrase. When I say sickle, you say the key pathophysiologic process is microvascular occlusion. And you should always have a picture in your mind for it. So when I say sickle disease, it should look like this. There's my microvascular occlusion from the sticky membranes of the sickled red blood cell. Okay, so that's at the tissue level. Okay, so which organs are affected? Which organs now are affected because they have a lower than usual oxygen level? So which organs are we going to see as disease here? Lung? Nope. Spleen, I like. Well, all organs have end arteries, don't they, at Najita? So yes, any organ can be involved, but remember what we're talking about. We're talking about normal organs. We'll talk about organs with disease because then any organ can be affected. But which are the normal organs that have lower oxygen levels by their architecture? So all those are right answers. Okay, you know what the magic phrase is? Anytime it's sinusoidal. Because remember what sinusoidal says. It says I go from this size and then I dilate up. Because that's what a sinus is, right? A sinus is a dilation. And the reason that matters is anytime you dilate up, you decrease the rate of flow. And when you decrease the rate of flow, the surrounding tissues extract more oxygen. So when we say then, which are now are my sinusoidal organs? That's going to be spleen, yes. Next, liver, well done. Yes, I like that very much. And one more, do you know it? Kidney's not sinusoidal, it's bone marrow. And the answer is anywhere you see cells coming and going through the blood vessel tend to have a very open structure. So if I say to you, what makes something sinusoidal? What makes something sinusoidal is this. It's going to have big gaps in the endothelial cells, and it's going to have an incomplete basement membrane. That's sinusoidal. And so what that does, it makes it very easy for cells to come in and out. So cells come and go from the bone marrow, the spleen, and the liver because those are macrophage things, right? Okay, so I'm going to take liver off the list clinically. Why is liver not going to be something that I worry about in sickle disease? Why is that sinusoidal architecture not a worry in the liver? It's got a dual blood supply. So when you take your non-diseased organs, you can see there's two organs that we're going to have involved in a normal person at rest. One is going to be the spleen, and the other is going to be the bone marrow. And then we say to ourselves, okay, how is that going to manifest in my patient? If I have microvascular occlusion in bone, what am I going to see? If I have a microvascular occlusion in bone, what am I going to see? Is pain, right? It's pain and possibly necrosis. I think that's perfectly fair. I like that. Let's add pain and let's add necrosis. And what am I going to see from the spleen? What do I see from the spleen? Quite the opposite of splenomegaly, Retina. I'm going to infarct it, so it goes away, right? Because remember, I'm going to lose my spleen. I'm infarcting it away. So how is that going to, if I lose my spleen, what happens to me? What does the spleen do? Encapsulated bacteria. That's going to be my clinical manifestation. So what now? Give me my three commonest encapsulated organisms that cause infection in humans. What are my three big encapsulated bacteria I have to think about right now? Big three, because you're going to vaccinate for them. Just think of the vaccines. So strep pneumo, Haemophilus influenza, Neisseria, that's going to be a big deal in your patient. Okay, so do you all see how completeness works? So every time you're studying, you're going to do two things that really matter. The first is no gaps. When you do a disease, you've got to be able to walk me through every step of the way and explain the disease to me. And the second thing that you've got to be able to do is you've got to be able to say, what is the key pathophysiologic picture? When you say sickle disease, what is the disease? It's not the sickled red blood cell. I mean, it's really iconic. We all see it in our mind's eye. That's fine. But the key thing is, when I say sickle, that's the disease that I see. Okay, so I want you guys to tell me this, right? But why do they get vascular occlusion? The sticky, not the sickling. It's the polymerization changes the cell membrane, right? Okay, so one of the ways we talk about this is, what if we said to ourselves, compare this to hemoglobin C? That's a really common question, because what's the difference between hemoglobin S and hemoglobin C? So now, instead of it being a valine, it's going to be a glycine. So now the question is this: does that polymerize? So if I do a lysine instead of a valine, does that polymerize? So all my patients have is anemia. So do they get microvascular occlusion? So now all of a sudden you realize calling it sickle cell anemia is really misleading, because it's not the sickle that's the problem, it's the sticky microvascular occlusion. And the anemia isn't really a big part of the problem. I mean, it's better to have a normal hemoglobin, right? So a better name for sickle cell would be microocclusive hemoglobinopathy. Wouldn't that be a better name for it? And so all of a sudden now you can see, how differently you're going to study, aren't you? You've got to be able to do every step, starting with your patient, pain, and infection. And you've got to walk me all the way back, making sure you can do the key concept underpinning the disease. Just never thought about this way. And doesn't this work better? I mean, don't you want to go see a sickle patient now? Right? And when you look at that little sickled red blood cell, what are you going to see? That sticky little membrane, aren't you? And just at rest, which organs are you going to think about? Spleen and bone, man, of course that. Can any organ be affected? Oh yeah, we're going to talk about complications pretty soon. So now guess what? You're all responsible for this. Okay? So when I say you're all responsible, what does that mean? When we talk about learning, there's what is called in medicine the forgetting curve. And I want you to think deep and hard about how you study, because this is really going to affect your ability to maintain all this stuff I'm giving you, right? If I say to you, let's do my learning curve. 1, 2, 3, 4, 5, 6, 7. So there's a week. And we start out here with 100% knowledge. When do you think you get to 50%? That's how fast you forget, right? You're going to have lost 50% of everything that I've said by the end of today. So what that means is, if you restudy again at day 2, what you're going to do is bring yourself up. But look how long the memory curve goes. And it doesn't fall off as much. And if you repeat it again at day 7, you can put it into your permanent memory. So what this says is, you've got to have repetitive learning. So as you go forward in all your classes, at the end of the first day, you get it to 100%. So that's day 1. You should have fully understood all of the material once. Sometime between day 2 and day 3, you'll learn it again. And sometime around 1 week, you do it again. And then you come back every so often, all the time. Okay? So when I say to you, this is how I want you to think of sickle, you make sure you can do it tonight, you do it again on Wednesday, and you do it again on the weekend. And so that means that medicine is repeating and repeating and repeating. Otherwise, you're learning and just forgetting. But now let's say, but my patient doesn't walk in the door and say, you know, doctor, my chromosome 11 has a single nucleotide polymorphism. And on my HBB gene, I've got a substitution of an adenine to the thymidine. It's just killing me. They don't say that, right? So you've got to take every disease that you've thought through and you've got to say, okay, but who walks in the door? And this process is very specific. It says, find a complaint that I know how to do a differential from. So that is called a chief complaint. And what that means is it's something that you have an approach to. And what that means is a chief complaint allows you to form a differential diagnosis. So we're going to say, what is my chief complaint here? So what's my chief complaint here? So we're going to start with leg pain. Now remember, when we do a differential, at your stage, it has to be by organ. So when I say leg pain, tell me all the things that you think of that could be leg pain. I don't have a big list here, but these are some of the things I could think about, right? It could be the bone. It could be the muscle and the connective tissue. It could be a joint, and it could be the skin. That would be a pretty good list for thinking of the various organs that could cause that, right? Okay, so you're going to look for this then by history and physical and testing. It's always that. And when you do our patient here, you'll be able to say, find the family of diseases. Okay, so this is basically going to be off the physical exam. You're going to look at the skin. You can test the joints. Does it hurt when does it hot, red? Does it hurt when I bend it? So that would be easy. The muscle and the joint and the connective tissue you could do by palpation. So you should be able to get to bone. That should be a pretty straightforward process off the physical exam. And then we say, okay, when I say pain, it has to be one of three primary processes. What are the three processes that give me pain? So nerves, so something to do with neuropathic. And one more, ischemia, right? So it's not artery occlusion, it's ischemia, because there's other causes than just the arteries, but I get it. Artery is a good answer, right? So anytime you see pain, those are going to be your three primary processes. Okay, well, if it's the leg and it's in the bone, there really isn't a neuropathic. So when I say our bone pain, what are our two pathologies here? Well, inflammation is going to be osteomyelitis, and ischemia in this situation is going to be my sickle cell disease. So how are you going to tell these two apart, right? We've got our little 14-year-old boy, and he's got this bone pain. How are we going to differentiate its sickle versus an infection on how the pain arises? Just started. I was walking around, got a little sore, got a lot sore, here I am. Because the problem that you face is this. When we talk about acute inflammation, you're going to have to be able to explain to me how that works. How does acute inflammation work? Because every time I say acute inflammation, I'm talking about one cell, aren't I? What is the central cell of acute inflammation? When I say acute inflammation, you say, how did I get a neutrophil there? Okay, so if I have a bacteria in my skin, so here's my skin and here are my bacteria. How does the body know they're there? How does the body know that I have bacteria there? When you first get infected, how do you know? Oh, well, yeah, for sure the immune system, Jay. Yep, but that's not going to get it done on completeness, is it? There has to be a signal. Yeah, I get it. But how does it do that? You can't just wave your hands. Little angels don't come down and carry the neutrophils there. I've got bacteria. Bacteria make a signal. The signal is going to be one of two things. It's going to be a PAMP or it's going to be a DAMP. What does PAMP stand for? That's a pathogen-associated molecular pattern. And there's my pathogen. What does DAMP stand for? This is going to be damage associated. So this is pathogen associated, and this is damage associated. So if I get hit by a truck and I crush all of my tissues, do I create a giant damage-associated signal? Sure do. If I have a big myocardial infarct and kill a big handful of myocytes, do I create a big damage-associated signal? Yes, you do. So they're both going to go down the same pathway, aren't they? Because they're both going to signal to what are called PRRs, which is a pattern recognition receptor. And in any tissue, these are found on two fundamentally important cells. What are the two cells that are in all tissues because they're there to look for a stimulation damper PAMP? What are the two cells I've got here? One of them is going to be my antigen presenting cell. Think a resident macrophage, right? But what's my second cell? The second cell is going to be this cell. So what cell is that? All your tissues are full of mast cells. And when these cells get stimulated, here's the PRR on each of these cells. When they get stimulated, they create their own signal. So what's the signal that I get from an antigen presenting cell? When my resident macrophage gets stimulated, what signal does she send out? IL-1, IL-6, TNF. Okay? Does everyone have to be able to do IL-1, IL-6, TNF? Yes, you do. So you are now, remember we talked about the forgetting curve? I'm assigning you acute inflammation. What are the two products I get out of mast cells? Histamine and bradykinin. And when we talk about what the effect of all these cells is going to be, is it's going to cause what? It's going to cause vasodilation. And the reason we need that is remember that my neutrophils occur in a marginal pool and in a central circulating pool. And when I vasodilate, they all come out and marginate. So I get margination. And at the same time now what's going to happen is my endothelial cells are going to dilate and I'm going to get all of these nice gaps. So there's my vasodilation. And what then happens is I'm going to capture the neutrophils, right? I'm going to capture my neutrophil here. There's my neutrophil here with slow rolling. How do I capture that neutrophil? How does slow rolling work? What's on the endothelial cell? This is going to be selectins to addressin. So that's going to be my slow rolling. And the next thing I'm going to get is it's going to be stuck hard and fast, right? So now it is stuck. Now what is going to make those two? What allows that neutrophil to come to a complete standstill and be adherent? This is going to be ICAMs on the endothelial cell to integrins. Give me my model disease here. What's my model disease here? What's LAD stand for? Right, that's my leukocyte, right? Because remember what they're missing is they're missing 11 and 18. So they literally can't adhere, so you literally can't have a neutrophilic response. Okay, so now how does the neutrophil know where to go? How does it know how to go? How does it follow to the bacteria? It follows the chemokine gradient. Okay, tell me what's in the chemokine gradient. What are the signals here? This is going to be IL-8, leukotriene B4, C3A, C5A. Those are all the gradients that we have, biologic processes. And then the last thing to understand is how easy is it for the bacteria to actually be seen, right? Especially if they've got a capsule. Well, I can increase the signal 1,000-fold by opsonizing it. So what are the proteins that I use? Opsonin. So what are the proteins that bind to the bacteria to make them really, really light up? Right, Jay, what are the opsonins? Give me the two most important. What are the two most important? So that's going to be my C3b and my FC portion of IgG. So what that means is to get that fluid out there, I have to have this open space here so that I can create fluid. So that's going to be my edema. Everyone happy now with how acute inflammation works? And that's how this goes, right? Every time we start talking about a little black kid with bone pain, and I say, well, tell me about inflammation. Well, now we've dropped down a whole level of basic sciences, haven't we? So you are now officially assigned this by me. When I say acute inflammation, you have to be able to do that for me. Every step. I don't want gauzy biologic processes, hand waving about immunity. Don't want to hear it. I want you to walk me through at the molecular level. You know how many times you have to write that out till you can do it? At least 10. And then you have to, having done it once, 10 times, so you can do it perfectly. You know what you have to do? You have to do it 2 days later. And you know what you have to do after that? You have to do it a week later. So when I say acute inflammation, I know that we're seeing the same picture. Is it a lot of work? Yeah, but you've already done a lot of work. Don't tell me it's a lot of work. You don't mind doing a lot of work if it matters for the exam and it matters for your patient care. Okay, so now you're perfectly allowed to say to me, okay, tell me in patient care why I need to know this. This is called hashtag make me care. Okay, so let's make you care. When I say, what are the hallmarks of acute inflammation? What would you tell me? In Latin would be great. What are the hallmarks? Great stuff, right? Really good stuff, right? So this is my rubor, tumor, pallor, dolor. Why are they red? Why are they red? Show me where on this graph I get redness. Absolutely not from red cell leakage. It's solely from the vasodilation. Why is it warm to touch? Again, increased blood flow, vasodilation. Why is it painful? Because bradykinin increases the sensitivity of our type C nerve fibers 1,000-fold. And it often interacts with prostaglandins to do that. So your bradykinin makes it painful. Okay, and then the last one is tumor. Why is it swollen? Because of this edema fluid. And that's an exudate, Jay. That's quite right. So every time you see what are the hallmarks of acute inflammation, and I say rubor, tumor, pallor, dolor, all they're telling you is you have this vasodilatory process with release of bradykinin from mast cells, and the vasodilation is opening up the endothelial junctions, so I get a transidate for opsonization and other proteins. You're not actually looking at the redness. You're saying, I can walk you through the molecular mechanism of that. So now when you can see why all of a sudden it becomes really hard and really slow to walk through even the most simple things till we build these basic ideas in, right? Because when I say to you, if I say to you osteomyelitis, that's acute inflammation, right? Why does osteomyelitis cause acute inflammation? What is the signal? What creates the acute inflammation? Yep, I see it, Prevent. Why do I have acute inflammation? This is a bacteria, right? But when I say to you infarct, now what is it? Now you can say it's a DAMP. But do they trigger the exact same pathologic process? Yes. So clinically, are they identical? So it's a problem. That's a problem, isn't it? And so at the end of the day, you know what the absolute best test is? To do a needle aspirate and look for bacteria. If you're really not sure whether it's infected or not, you go looking for the bacteria by aspirating the area of involved bone and looking at it and culturing it. And doesn't that just make great sense? Okay, so look what we've done here. We've stopped and said, hey, show me a really good disease that teaches completeness. Man, isn't sickle cell really a good disease to think about? Every step of the way, you can see something, single nucleotide polymorphisms, giving you a single amino acid substitution, so polar goes to neutral. In low oxygen, that polymerizes, and you see the cell, but the big thing is it upregulates all the membrane proteins and makes it sticky. So the true pathophysiology is microvascular occlusion, which we see in areas of low oxygen, which is sinusoidal. So that's bone and spleen. Well, what would we see in bone? Well, in bone, we see ischemia. And so ischemia is one of my 3 basic causes of pain. And now all of a sudden we flipped the problem, right? We've flipped it from seeing it from the tell me the pathology to show me the differential for the patient. And you got to be able to do both. And now you can see, now we get to do that for every friggin' disease. And it takes a long time because you really have to think much more thoroughly. Okay, let's come back now and let's talk about bradykinin and pain. Okay, so where do we get pain? What is pain? Walk me through the medical pathophys of pain. Because we have 2 sensory long tracks, don't we? What are my 2 sensory long tracks in neurology? Okay, so when we say, tell me about pain, okay, so we're on a whole new subject now of pain, and we're going to say spinal thalamic, yes, and dorsal columns, right? So those are going to be my, when I say, tell me about sensory, I have 2 major problems, right? So what do my spinal thalamics do compared to my dorsal columns? What do they sense? Whereas when I come up to my spinal thalamics, these are going to be my pain and temperature. Okay, what are most of my pain nerves? They're mostly unmyelinated C fibers. So when we say, how do I feel pain? It's because there's a stimulation to the C fiber, which is programmed for injury and inflammation. And when we say, well, what affects it? Well, a couple of things affect it, right? We know for sure that bradykinin affects it. It increases its sensitivity response 1,000-fold. And it's probably also true that prostaglandins affect it as well. Okay, so when you say to me, tell me about pain, right? Again, walk me through the basic sciences. And now what I could do if I was sort of saying, okay, well, let's follow this. Now you have to walk me through all of these tracks, starting from the peripheral nerve, showing me the first synapse, walking me through where it goes in the spinal cord all the way up to the thalamus, and then that's how it's relayed onto what part of the cortex. So every time you're studying, clinical medicine is what? Built on a foundation of basic medical sciences. Can you see that? Right? And basically, you're just going to spend the rest of your lives learning this. Every time you see a patient, you walk me through to the basic science principles that underlines that case. So we've used sickle cell 2 ways, right? We've done sickle cell to show you completeness. And man, weren't there some big gaps? I mean, it's really sad when you sort of go, wow, I've actually studied this and man, I had these big gaps. But the other thing is to say, but who walks in the door? Now we're talking about bone pain, and all of a sudden we have to say inflammation, and PAMPs and DAMPs can be difficult to differentiate because they're both neutrophils. They're both acute inflammatory responses. It's a totally different way of thinking, isn't it? And you sort of go, mostly you're just swallowing hard and saying, dear Lord, this is how doctors think. Oh yeah, it really is. You start with your patient and you walk me all the way through to molecular. Once you get a diagnosis, every time I give you a diagnosis, you should be able to tell me presentation, pathophys, natural history. Okay, so let's just take a look, and then we'll take a break. Okay, we've done sickle. So here's my hemoglobin S. How does it present? If I said to you sickle disease, what would the symptoms be? The classic symptoms of sickle cell. Pain, absolutely. So the first one we're going to talk about is bone pain from ischemia. That's a classic presentation, right? And what would the other classic presentation be? But the other one, of course, is going to be the bacterial infections, right? Why do they get encapsulated bacterial infections? Why do they get infections from encapsulated bacteria in sickle cell disease? Right, and so here's the question, Nida. By what age have they infarcted it? So by what age are we expecting bacteria? When have they completely lost their spleen? When have they autosplenectomized? How would you know that they have lost their spleen? What test could we do to prove that? How do we know when they're functionally asplenic? Okay, what we would do is we would do a peripheral blood smear, and when I looked at their red blood cell, I would find in it a blue blob. And what would that be called? That's going to be my Hal Jolly body. And that's when you know, man, you'd really better get after vaccinations. What am I going to find on physical examination? Presentation, pathophys, natural history. Presentation is symptoms, signs, and testing, okay? So what am I going to find? Not much. Physical exam is not a big part of this disease. And then what am I going to do for testing? How do I diagnose sickle cell disease? How do you diagnose it? Let's go get a sickle cell, right? But I only see that when they have a crisis. So that's not going to work most of the time, is it? What we want to do, so nothing wrong with that choice, it's just not going to work very well. What we want to do is a hemoglobin electrophoresis and look for the hemoglobin S. When I say pathophys of sickle cell, what picture pops into your head? See the picture? Every disease I talk about, I have a little picture in addition to the words, okay? And so should you. It's really easy to draw these little pictures out and they're permanently in your memory. Okay, so this is where almost everybody stops. But then remember, you've got to sit down with your patient and his mom, and you got to say, what does this mean to me? Can we do anything about it? So this actually becomes one of the biggest gaps in most medical students' knowledge because they're not actually treating patients yet. So if you are homozygous, what is the prognosis of sickle cell disease? What are you going to tell mom about her little, 4-year-old boy with a bone infarct? What are you going to tell him? Yeah, well, how bad? How bad, Rachna? In America right now, they are dead in their 30s. What are the complications that we look for in this disease? What are the complications? So now that you've made your diagnosis, what are you looking for in your patient? What are we looking for? Because obviously we ask you this all the time, right? So stroke, absolutely, they can have microvascular occlusion in any organ, and stroke is devastating. The biggest and most important one, though, is acute chest syndrome. This is now the #1 risk of death in Americans with homozygous sickle cell. So that's obviously a really important disease. Tell me about their hips. What do we see in their hips? What do I see in the hips? Avascular necrosis. What virus do we fear? What virus do we have to watch for? Leg ulcers, nice. What virus do we have to watch for? Parvo B19 can give them an aplastic crisis. Okay, what would I think about if they had gallbladder disease? What do I have to think about in the gallbladder? What do I have to think about in the gallbladder? Well, they get stones. So you can see as we go through this, what particular bacteria do I have to worry about? What unique bacteria do they get? What unique bacteria do they get? They get salmonella. No, they get the encapsulated, but they also uniquely get salmonella osteomyelitis. It's quite unique to them, and no one's exactly clear why. So now all of a sudden you realize, wow, I actually have to think a lot about sickle cell disease, don't I? And then the last is, how do we treat them? So what are we going to tell mom we're going to treat her little child with? What are the keys to therapy? What are we going to do? Well, strep tells us for sure vaccination is going to be a big part. These kids, because these infections are such a big problem, they're all on penicillin G until age 5, because this acute chest sequestration is such a danger to them. Other things we do is hydroxyurea, because hydroxyurea increases hemoglobin F, which is protective. We have to give them folate, because they have a very active red cell production and it's easy to get vitamin deficient. Okay. And then during a crisis, not as a matter of routine, but during a crisis, now you can transfuse. But you notice most of our care is not during crisis, is it? Okay, so look what we've done. We've just spent basically a whole hour talking about how you think about one disease. Now, it's an important disease. I'm not knocking that. I'm just saying, do you see how deep the understanding has to be? You can't just wave your hand and say immune response. You've got to walk me through the molecular of PAMPs and DAMPs all the way through to your opsonins. When I say I've got a disease, look what you have to do for presentation, pathophys, and natural history. And believe me, this natural history, that's something you've got to consciously practice because you're not actually treating patients as the primary doctor yet. Okay, so as we go through and we're saying, what are you going to have to do to go right and succeed on your American exam? It's not enough to have a lot of facts. First of all, we've talked about you've got to be complete in those facts. Second of all, you've got to be able to get to the disease through the clinical reasoning of chief complaint to differential diagnosis to family of disease, and then the testing here to make the diagnosis. And when you get a diagnosis, presentation, pathophys, natural history. Everyone with me so far, right? You can appreciate you're not going to cram for the STEP exam, are you? You're not going to cram for it. You're going to really go back to all your books and you're going to organize them from a patient-centered learning. So let's get back to these ideas of patient-centered learning. Really feels different, doesn't it? So for the first time is you've got to start from your patient. You got to go all the way to DNA, no gaps. Got to have cells and ultrastructure and proteins every step of the way. And then the next thing we said was, and remember, starting with a patient, it's always going to be chief complaint to differential diagnosis by organ, find your family of diseases, and then testing takes you to a specific diagnosis. There's always that order. And so that's the way all your question stems are going to be written too. When I write a multiple choice question, that's what I do. Okay, so let's start again with our next patient. Here's our next case right here. All right, all you young doctors, what is my chief complaint? Always starts with chief complaint, doesn't it? So what is my chief complaint? Pretty straightforward, right? So what you're going to notice is in medicine, there really are a very standard number of chief complaints. All of us recognize it, and we recognize it because it's common and we have an approach to it. So if you go to our website, which is included with your MOKSH thing, you will see if you go to chief complaint differential diagnosis, you'll see that we've actually written out about 55 to 60 of the most common chief complaints and how to do a differential from them. So you can appreciate this is one of the most standards, which is chest pain. You got to be able to do abdominal pain, shortness of breath. There's a number of standard chief complaints in medicine, and you know you're ready to write your STEP exam when you can identify them and do a differential from them. Okay, so we haven't done much on the way of clinical differentials, but obviously we're going to spend lots of times doing it. Here's what I want you to see is I think there's actually a really good way of remembering how to do the chief complaint of chest pain. Whenever I can, I always try to have a picture of how I think about things. So when I talk about chest pain, I do this anatomically because there's a number of anatomy views that are so standard in medicine, everyone's got to be able to do them. And the standard one for chest pain is a transection of thoracic vertebra 6. Okay, watch this. I'm going to draw it because I see it in my mind's eye. If I'm going to draw T6, look what this looks like. So there's my T6 vertebra, right? And there's my chest. And the reason you got to be able to do T6 is it's a really standard view because there's my ascending aorta. And then around that, I'm going to have my heart. And then there's going to be my left ventricle there. So this is called the bullseye view because of that ascending aorta. Okay, watch what I'm going to do. I'm going to go from anterior to posterior, and I'm going to use it as a way of remembering my differential diagnosis of chest pain, right? Okay, watch this. Okay, number one, what am I drawing right there? What structures did I just point out to you right there? Anterior chest, right? So think about it. I'm looking towards the head, right? So this is my right side here. What structure did I just draw there? Okay, ribs, but look what I did. It's actually right here. Can you see that? Right? Because I didn't just draw a standard rib. I specifically did two of them right there. What am I drawing out? Sternum. Okay. If I was doing sternum, I would have done this though, right? Nothing wrong with sternum, but I would have said, there's my sternum, right? How do the ribs join the sternum? How do the ribs join the sternum? Well, they join it with cartilage, right? It's a costochondral. So anytime you're doing a lot of work beyond your fitness level, which is the weakest part of your chest wall, is that cartilage, right? So when we're talking about causes of chest pain, chest wall is, but the classic pain here is going to be costochondritis. So in here, you know, in a northern climate here where you get a heavy spring rain, or you go out and help your brother-in-law build a deck, or you do something that you're not fit enough for and you're putting pressure on the actual skeleton of your chest wall, you can get costochondritis. And it really imitates angina. It's really similar. So what is the test we're going to use here? You just palpation is fine. You put your big fat thumbs on your patient and you push it, goes, is that your pain? Oh yeah, that's my pain. You'll still get your EKG and your troponins, but you know where you're going. What am I showing here that can cause chest pain? What are those guys right there? What am I showing? Which organ am I in? I'm showing you right along the outside. No, ribs would be chest wall. So this is going to be my pleura. I agree, it's a little bit of an unfair picture, but that's going to be where my pleura is, right? Okay. So what is the pathology that's going to cause pain in pleura? Okay, well, that's pretty easy. That's going to be pleuritis. And how am I going to diagnose that? How do you diagnose pleuritis? What am I looking for? Auscultation defined what, Jay? A rub. The next one I'm going to do is this guy here that goes all the way around the heart. What am I showing you there? Sure, so that's going to be my pericardium. Okay, so that's going to be pericarditis. And how am I going to diagnose it? How do you diagnose pericarditis? You're going to have a rub, right? Again, it's acute inflammation. Okay, number 4 is going to be my ascending aorta. How could my ascending aorta cause pain? Ascending aorta, how does it cause pain? If I'm dissecting my aneurysm, isn't it? Okay, how am I going to diagnose it? I'm going to do imaging. Okay, if it were me in my age group, I'm 68, what would be my predisposing risk factor for a dissecting aneurysm? How would I get a dissecting? How do I get an aneurysm? Yeah, that's right, Jay. In old people, it's hypertension. But in you guys, what would it be? If you're 30 years old, what would it be? Not hypertension. Strenuous work never harmed anyone. As attractive as that theory is, it's actually not true. If it's you guys, it's going to be inherited, not obesity. No, obesity can give you hypertension and you're back to me again. It's going to be Marfan's, right? If you're young, and I guess we better talk about this, it's going to be hereditary, and that's going to be Marfan's or Ehlers-Danlos, Marfan's being more common. If you had a 30-year-old with that tearing chest pain radiating through to the back, on the physical exam, how would you suspect there's Marfan's? How are you going to do it? Right there. There's your patient on the bed. What are you going to do for Marfan's? Really hurts, doctor. Get going here. Marfan's, right? And what is the underlying thing? So I can either do the wrist sign, which says when I do this, my fingers actually overlap. I don't have Marfan's. What's the other one I can do? The other one I can do is a fist sign, and my thumb is so long that my thumb sticks out the end here. Because what is the hallmark of Marfan's? It is, know the word for long fingers and long toes? Arachnodactyly. And arachnode is what in Latin? Arachno is spider. So they have spider hands. So when you've got that 30-year-old with that terrible chest pain dissecting, quick and dirty, go look at the hands, really long fingers and thumb, arachnodactyly. In me, it's hypertension. So old hypertension, inherited Marfan's. How do you tell Marfan's from Ehlers-Danlos? So quick and dirty, how would you tell her from Ehlers-Danlos? Right? They have the very lax skin and the really hyper flexible joints. You notice all of a sudden, wow, patient-centered really organizes information differently, doesn't it? Okay, number 5 then, that's going to be my angina. And number 6 is going to be right here. What structure do I find right there? Right there. What structure is that? What structure, doctor? That's going to be my esophagus. So that's my esophagus. So what's my pathology that gives me commonest cause of pain in the esophagus? GERD. Excellent. And how do I diagnose it? Well, Boerhaave's, but that's associated, but we should associate that with violent vomiting, right? So if they told you a history of vomiting, that's a great answer. So GERD would be commoner, Boerhaave's is fine. That's a great answer. I like that. Thanks. How do we diagnose it? How do we diagnose GERD? We're going to do endoscopy and you look for inflammation. Okay? So now all of a sudden you realize we're developing this idea of patient-centered. Manometry is perfectly fine. That's part of the diagnosis as well, Nida. That's great. So now all of a sudden you realize you got to go through and be able to do all your standard chief complaints, and none more important than chest pain. And look at that nice little picture you have there. So now I've assigned you sickle cell completeness, acute inflammation, DAMPs and PAMPs, and now you can see I've assigned you the differential diagnosis of chest pain. How many times do you have to practice it? At least 3 times this week, and then you come back to it every month or 2. Okay, so this is a mandatory. Okay, so let's go back to our patient. So here's our chest pain. Based on the history alone, what would you bet of that differential diagnosis? What would you bet he's got? Just based on the characteristics of the history. Well, I like Nida's much better, right? Nida, so think, oh, and then she blew it. Started so well, Nida, and then crashed and burned, right? So notice this, right? So chest pain with exercise. If I wanted to know what I'd know next is, but when you stop, is it relieved? So if you get the chest pain going up and then it's relieved by rest, an exercise rest in the chest, that's going to be a classic example of stable angina. So what's the commonest cause of stable angina in America? It's an American exam. Sorry, you're kind of stuck with that. What's the commonest cause of stable angina in America? Well, no, but what's the pathology? What is the pathology of stable angina? In America, it's so common, we call it CAD. What does CAD stand for? Right? CAD stands for coronary artery disease. And by that, we mean atherosclerosis. So now all of a sudden you realize I've got a whole presentation, pathophys, natural history, don't I? Okay, so when I say atherosclerosis, what picture do you have in your head? Every pathophys has a picture, doesn't it? So when I say atherosclerosis, what is the picture you have? Plaque. Plaque is exactly the right answer, Bikesh, right? And when I say plaque, have you got a picture? Right? So when I say what is the picture that you got your artery, and then you got your plaque. And these are the elements of the plaque that you got to be able to describe to me. The first element of the plaque is the thick cap. There is a fibrous cap. That's an important element of that. The second thing you've got to be able to describe to me is how much inflammation. And then the third thing you've got to describe to me is there necrosis? So you've got to be able to walk me through how atherosclerosis develops and how it progresses. So this is a full pathophysiologic discussion, isn't it? But look what I'm going to do when I say, yes, but walk me through the patient's full story. Because you notice every patient starts pretty normal. And then onto this, we put 2 different patterns, right? We have hereditary and we have environment. And when we go to environment for atherosclerosis, we have those that can be modified and those which are non-modifiable. So the second I say atherosclerosis, you're going to say, how did this all begin? Okay, what is the most important monogenic hereditary problem? Because if I was going to ask you an exam question, I'm going to ask you that. So what is the single most important monogenic hereditary risk for atherosclerosis? And now all of a sudden we've got a disease, presentation, pathophys, natural history. Okay, so when I say familial hypercholesterolemia, what is the picture you have in your mind? When I say familial hypercholesterolemia, what is the abnormality? Isn't that great? So you've done all this studying, and when I say the disease, you don't have the right picture in your head, do you? Because all those are important, obviously. But why is the LDL high? Akish, you didn't ask yourself, why is it high? Because it is a mutation in which protein? It's a mutation in which protein? It's a mutation in the LDL receptor, isn't it? And because you need the LDL receptor to clear LDL, if you get a defect in the receptor, you get very high LDLs, and that LDL causes plaques. So when we say the most important of these is going to be an LDL receptor, right? And it's pretty common. You find it in about 1 in 200, 1 in 300 Americans. It's one of the two most underdiagnosed hereditary diseases in America. Okay, so that's a really good hereditary disease. I guess we should know that one. Okay, when we talk about environmental, what are the 3 things that you can't change that give you a risk for coronary artery disease, atherosclerosis? Well, look what they are. Age, the older you get, the most likely they are. Age, gender, so if you're male. And then the last one is family, but now this is polygenic. And that's by far and away more common than the very specific LDL receptor mutation. Okay, what are the modifiable risk factors? Because that's what really matters to doctors, right? Okay, and that's the great list, right? So here we have diabetes mellitus, hypertension, smoking cigarettes, homocysteine, right? Those are the classics. So when we take a look at this patient with chest pain, in our minds we say it started way back there. And then he started developing his plaque, but his plaque was only tiny at the beginning. So when do I see the first symptoms, right? This is going to be asymptomatic. When do I see the first symptoms? A stress that's going to tip you into failure. Tell me about the plaque. When do I see my first symptoms in this patient? When do I see it? If I was following the coronary artery and the plaque, okay, most of the time we're going to say it's about 70%. 80% is perfectly fine. 70, 80%, right? 60% is good. Let's make it 60 to 80. We all agree to that. That's perfectly fine. There's no precise point. Okay, why there? Clinical medicine is built on a foundation of basic medical sciences. Why 70%? So when I say this is a demand ischemia, meaning when I increase the demand, I can't make up for the difference. And I say, here's my plaque, and I'm going to see it here when it's a 70% occlusion. Why? What is the underlying basic science principle of this? It's a long dead Frenchman, I'll tell you that. And his name was Pucelle. Because if I was going to say to you, almost, not quite, not bad, Nida. If I was going to say to you a demand ischemia is this, isn't it? Here's my supply and here's my demand, right? So when I say supply, I've got 2 things that matter here. I've got my oxygen content and I've got my flow. And if I come over here and say, well, what determines how much energy the wall needs? It depends on wall tension. It depends on heart rate. And it depends on contractility. So that sort of sets it up, right? So when I say 70%, that is this. And flow is driven by Puicel's law. What is it? You've all done phys, and guess what? You all forgot it because you didn't know why you friggin' needed it. Well, now you need it, don't you? And this, we're going to ask you on this basic science is Puicel's law. And Puicel's law says that flow equals the change in pressure, so that was perfectly fine, times r to the 4th over viscosity times length. So when you say to me, what does the 70%, that's when r to the 4th becomes too small. R to the 4th. And if you don't get a question on r to the 4th on a general medical exam, that's a sad excuse for an exam. Okay, so there's flow, right? So flow is Puicel's law. Tell me about oxygen content. Who can give me the oxygen capacity formula? Who can do oxygen capacity formula, oxygen content? equals, I'll give you a hint, 1.34 times the concentration of hemoglobin times the saturation of oxygen plus 0.003 times the PaO2. That hurts, huh? Remember when you forgot that about 2 years ago? But now for the first time, you need it to explain it, right? So when I say to you, how does that matter in clinical medicine? It matters because anemic patients can get angina, right? So when you do O2 content, that's going to be your hemoglobin. When you do flow, that's R to the fourth. But again, once you know why you need them and you have the key pictures that you need, you can practice. Let's do number 3. So number 3, this is Laplace. And Laplace says the amount of energy you need to open the aorta and make it go, the wall tension, equals the pressure. In this case, it would be the aortic valve, right? Times the radius over 2 times the thickness. So that if you're pushing out against hypertension, you're going to increase the thickness. So heart rate, that works perfectly. We get heart rate and contractility, right? Contractility, this is related to concentration of calcium in the cell, and we don't have a test for that. But you can see when you take a look at our patient here and you say to me, he's got chest pain on exertion, that's a demand ischemia, and all of a sudden you're doing this, aren't you? And there's a lot of really good science underpinning that. So when I say 70%, that's really quite a statement, isn't it? There's a lot of science behind that 70%, isn't there? 70% sits on top of this gigantic piece of basic sciences, right? Okay. So when do I get severe disease? Well, now I'm just increasing, right? This is going to be greater than 70%. When am I always in chest pain? How severe an occlusion do I get before I'm always in chest pain? And the answer is greater than 90%. That means even at rest, you've got this little tiny hole. But look how long. This patient had this disease for years to decades before anything. Okay, so here's my question. He comes from all of these risk factors, right? And right here, he's asymptomatic. You can ask him till the cow comes home. He's perfectly fine. What are you going to do to test him? How are you going to test him here when he's completely asymptomatic, but has all these risk factors? How are you going to test him? If I'm going to stress test, how much occlusion do I need? Right? More than 70%. What are we going to do for 30%? Is that going to find 30%? No, it's not. Okay, cardiac markers. What do cardiac markers show? What do cardiac markers show? They show infarction, right? You're going to see troponins released. No, that's why we're practicing here. That's going to be necrosis. That's not going to help you at all. That's only when he's infarcted his heart. Okay, lipid profile. If my lipids are high, does that mean I've got atherosclerosis? That's a risk factor, but doesn't, right? So, okay, I get it. It's a risk factor, but it doesn't prove it, does it? Angiography, well, that's a great test, Rachna. But is that a screening test? Are you really going to do an invasive procedure and shoot dye as a screening test? So you're absolutely right. It's a great test, but it's a diagnostic test, not a screening test. So this is the idea that you've got to keep in your mind. The next principle that we need is to say to ourselves this. Tell me what is dystrophic calcification? What is dystrophic calcification? But EKG, but is an EKG going to be abnormal if I have a 30% occlusion? Right? Let's just get Jay's EKG out of the way here. If I have a 30% occlusion, is that completely normal? So that's a lousy screening test, right? Right. So you're absolutely right, Rachna and Jay, right? Dystrophic calcification we see in any process in which there is degeneration and or necrosis. So what is atherosclerosis? Is it degenerative necrosis? Yes. So if I went looking for calcification in coronary arteries, so if I looked for coronary artery calcification, if it was positive, what are the degenerative necrotic diseases of coronary arteries in Americans. Yeah, there's only one that matters. There's only one that matters, right? So this is now the single best screening test basically out there when you're looking for asymptomatic disease. And so when we say, what does this tell me? This tells me, look at this acronym. This is the risk assessment for atherosclerotic cardiovascular disease, right? So that's atherosclerotic cardiovascular disease. And so if your coronary artery calcification is positive, that equals high risk. Now you could go on to an angiogram. But if your coronary artery calcification is negative, that equals low risk, and you don't have to do anything more. Okay, so when we say risk, what does that mean? Okay, so there it is. There's the word risk. You've all seen it. It seems self-evident, but what does that actually mean? This is what it actually means. It means the likelihood of a cardiovascular event in the next 10 years, 10 years, 10 years, right? So high risk is greater than 10% likelihood, low risk is less than 5%. But when you think about how aggressively you're going to monitor and treat your patients, this is a really good test. Isn't that fun? So when you take a look and you say, okay, how am I going to screen? We're actually going to use, let's look for a degenerative process. So that's going to be coronary artery calcification. But now we're into symptomatic disease. So what test are we going to use in symptomatic disease? What are you going to do as your screening test? Angiography is always the gold standard. So I'm not going to say it's wrong. I'm just going to say it's not the screening test. What's the screening test? If I walk in and you do me, have I got any changes? No, because you've got to recapitulate what? What do you have to recapitulate? The demand, right? I only become symptomatic during the demand, right? So you've got to do this is my exercise EKG. And then once you're always symptomatic here, well, that's just always positive. So now you can just do an EKG and an angio, that will work fine. Here's my point. You notice all of a sudden when we're talking about atherosclerosis of coronary arteries, you notice I didn't start with a symptomatic patient, did I? I started all the way back here at the beginning, identified my risk factors. I went through my compensated period, and I moved all the way through stress into failure. And each of these required a different way of thinking about my patient and a different way of testing. So all of a sudden now, you can't just start with a coronary artery disease is angina, right? All of a sudden, you've got to walk me through the less than 70%, 70 to 90%, more than 90% occlusion. So natural disease of a chronic thing is you've got to walk me through all the progression of the pathology. Pathology is not just a moment in time. The last thing I want to point out to you, you've had all these choppy subjects. You've had biochem, and then you had phys, and then all of a sudden you got a patient presentation. But what I want you to think about is this. The body has to regulate itself at multiple levels. And every level that we have here does a different assay, okay? So let's just take this patient, and I want to show you how every level requires a different understanding, so that as you approach your patients, you do the whole person, the organ, and the cell. They all are regulated. So let's take our first patient here. Here's our patient right here, 74-year-old female. So what's my chief complaint? Right? Okay, so my chief complaint, this is such an important standard one. This is shortness of breath. It's always written that way. Sometimes it's added on exertion. That's allowed. Okay, what is my differential diagnosis? And remember, by organ. What are the two key organs that give me shortness of breath? Lungs, good, and heart. Now let's talk about the family of diseases. How do we think about lung disease as its families? How do we break up lung disease? This will be obstructive and restrictive. But if it's heart disease, what heart family gives me shortness of breath? Left ventricular congestive heart failure. So that's a thing. That's a specific family of diseases that presents with shortness of breath. Now let's go through and let's walk through what we have to know before I can talk to you about left ventricular congestive heart failure. So the first thing we do is every time we say the heart as a pump, you've got to be able to tell me these three key formulas, okay? The key formulas are this: blood pressure equals cardiac output times total peripheral resistance. Cardiac output equals heart rate times stroke volume. And stroke volume is proportional to preload, afterload, and contractility. You're never talking about the heart as a pump, that isn't how you're going to do all the classic physiologies of what it needs to be the pump. So let's go through and let's take a look at all of these functions. The term homeostasis is the term that is used to describe the normal range. In other words, it can be expected that as a normal human, you're going to have to be able to sit and run, and they've got to produce higher cardiac output when you run. Adaptation says this is not enough, right? So we have to do something because this is pathologic. And then disease comes when it says neither homeostasis nor adaptation is there. So disease says I'm having moments when the organ doesn't do for me what I need it to do. And every time we talk about a disease process, you're going to build it onto these structures. Okay, so here's the question I've got. How does the body monitor cardiac output? How does the body monitor cardiac output? Right, it doesn't, right? Isn't that interesting? Good job, Nida. It doesn't monitor it, right? What it monitors is blood pressure. So if I said to you, give me the picture that says, how do I monitor blood pressure? What are the 4 places that it monitors blood pressure in the body? Give me the 4 places that it monitors blood pressure. The juxtaglomerular apparatus monitors it and then adjusts it. So RAS is the effector. It's not the measurement, right? It's monitored through the cells of the juxtaglomerular apparatus, which includes the macula densa and the renin-producing cells, right? Okay, sympathetic tone, Jay. What does that mean? What is the measuring cell? Sympathetic is the effector mechanism, but what cell detects blood pressure? Okay, not specific. I'm not going to live with that, Jay. Okay, that's much better, Rachna, right? I've got cells here in the ascending aorta. Those are baroreceptors, and I've got them here in my carotid bifurcation. So these are baroreceptors. So there's 1 carotid, 2 JGA. I need 2 more. 2 more. In the brain, what structure in the brain monitors volume and pressure? So what in the brain monitors it? Hypothalamus. And then you ready for this last one? Right there in the right atrium is number 4. The right atrium monitors volume. Okay? Now what you've got to do is, and when they detect it's too high or too low, what do? It's up to you. Here we're going to go. Carotids go through 9. Arch of the aorta goes through 10. Where do they go? So watch what I can do now. Everything you can do is a picture. So if this is my brain here, watch what I can do. I can give you my corpus callosum. I can give you my fornix. And then I'm going to come down here. There's my optic chiasma. There's my pituitary mammillary body. And there's my midbrain. Coming back down, there's my pineal gland. And there's going to be my tectum. And there's going to be my cerebellum. Here's my pons. And there is my medulla. So when I draw this in, there it is in the medulla. Where? It's not enough to say medulla, right? That is my nucleus tractus solitarius. And when the nucleus tractus solitarius doesn't detect enough, what does she do? If I've got a decrease in blood pressure, what does she do? Okay, but she doesn't actually do vasoconstriction. What does she actually send it to? You've all been hinting around. I mean, Rachna's got it right. She goes to the parasympathetic nervous system or the sympathetic nervous system. Now watch, I'm going to draw it. You don't have to imagine it. You can draw it. Look at, there it is right there. It's going all the way from T1 to L2. And that's going to go to 3 major effective organs, right? It's going to go over here to my heart. It's going to go here to my adrenal medulla. And it's going to go here to my kidney. And I can draw you in a JGA, right? And that's going to be my RAS system. So when I say to you, look what we just did here, I want you to tell me, I want you to tell me what happens here, right? We have 4 homeostasis, right? We have our baroreceptors, we have our JGA, we have our hypothalamus, and we have our right atrium, which is going to release my natriuretic peptides. And my hypothalamus is going to be my ADH, my JGA is going to be my RAS system, and my baroreceptors are going to be my autonomic nervous system. So when I say to you, tell me the systemic physiology of the heart, you can see why we're going to write neurohormonal. Neuro for the autonomic nervous system, hormonal for all the others. When I say, if that's not enough, what does my heart do? And the phrase you've never built in here, but it's perfectly true, is the heart is going to remodel, right? And that's where we talk about our concentric and our eccentric. And the signal that's going to be for that is this is going to be cytokines. And then when we say, well, what happens in failure, right? For the one we've talked about, this is going to be left ventricular congestive heart failure and right ventricular congestive heart failure. And you got to describe those patients. Yeah, that's not enough. It's ischemia, you got hypertension, you got an aortic stenosis. Well, the heart has to change. It's going to remodel. And when that's not enough, well, we get disease and it has symptoms. Okay, but look what we've also got to be able to do. You've got to be able to come down and say, but what happens actually when we're signaling in the heart? So now all of a sudden we're talking about how does the sympathetic nervous system work, right? And now all of a sudden we're talking about heart rate and contractility. So you've got to be able to walk me through what's happening at the level of the myocyte, and you've got to walk me all the way into the proteins. So now you've got to be able to talk about my beta-1 receptors, both in the SA node and in the myocyte. How does it actually affect that change? So clearly, if we had more time, I would make you draw that out for me. When we talk about what happens with my remodeling, now we're going to be talking about concentric and eccentric hypertrophy. We're going to be talking about Z lines here, right? So there's my Z, because that's going to be my contractile unit. And now all of a sudden we're talking about going from this, if it's concentric, it's going to look like this. I'm going to add sarcomeres. And when we talk about disease, right, now we're going to talk about dilation and fibrosis. And when we say, well, what's happening here at the myocyte level, this in here from my myocyte, this is where I'm going to draw these classic decompensation curves of my Starling curve. And when you come over to disease, we're going to be talking about fibrosis and apoptosis. So all of a sudden you realize we're not just getting by with a few scattered random facts. We've got to be able to think about how this disease occurs with its insult over time and how it goes through neurohormonal, and then it makes permanent genetic changes with adaptation. And then, of course, this is when our patients develop symptoms and signs. So a lot to learn and a lot to think about. And when you come back to me at the end of this course, I'm going to ask you all of these because you need them all for patient care. I want to finish up just on this picture here. I want to show you how we would do congestive heart failure. So when I say congestive heart failure, left ventricular congestive heart failure. So we're doing shortness of breath from left ventricular congestive heart failure. Every time I have a pathophys, you need to have a picture because words just go. So when I say left ventricular heart failure, when you come back to me, this is the picture I'm assuming you have in your head because this is the picture that every doctor uses. So let's draw ourselves a heart, and let's draw ourselves a left ventricle and a right ventricle, a left atrium, there are my pulmonary veins, and there's my right atrium. Everyone happy with that picture? And then what's going to happen is we're going to have my pulmonary veins come off it until I get to an alveolus. So when I say to you left ventricle, that's the picture I expect to have. Now let's have it go into failure. What is the definition of failure? Well, it actually, if you go to a cardiologist will say it's any time I have an increase in left ventricular and diastolic pressure and or volume. I'm just telling you, we don't have time to go through all the pathology, but that's our working definition. So every test that's going to prove congestive heart failure is going to work because it shows that. So let's go through a progression of disease. As my heart has a disease, what is my first compensation going to be? When cardiac output drops, so blood pressure drops, what's the first response of the body? First response is going to be, we're going to batch that as neurohormonal. So when I say neurohormonal, right? When I say neurohormonal, this is neurohormonal. Everyone's got to be able to draw this picture out all the way through, right? So when I say neurohormonal, right, that's our first adaptation. When that's not enough, what comes next? When that's not enough, you've flogged it with the sympathetics, you've added ADH out the wazoo, aldosterone's pouring out. What comes next in the body? Right, this is going to be remodeling. That's what's next, right? So that's my concentric and eccentric hypertrophy. And when that's not enough, then I go into failure, and that's what that is. So everyone see, when I say left ventricular congestive heart failure, I expect you to see it that way, right? Okay, so when I draw this heart, obviously this is the first thing I'm going to see. I'm going to see remodeling, aren't I? And then as this pressure increases here, it's going to back up through the system. So it's going to increase the pressure in my left atrium. And then it's going to go down and it's going to cause an increase in pressure here. And so I'm going to get edema. And when that pressure all the way back here is greater than 20 millimeters of mercury, normal should be less than 5, what I'm going to see is I'm actually going to get edema in the alveoli, and that's going to give me shortness of breath because I have a diffusion defect and I have VQ mismatching. Everyone see that as the universal picture of congestive heart failure. When I say left ventricular heart failure, that's the picture in your head. Now what I'm going to say is this, doctor. If this is the definition here, this is my definition, I'm going to give you a stethoscope. How do you diagnose congestive heart failure, right? By showing me one of these pathophysiologies. Okay, Nida, that's great. Why do Crackles prove congestive heart failure? I like the answer. It's a great answer, but why? Why do Crackles mean, okay, good, walk me through. So edema, what does edema mean? What does edema mean? Yeah, it's fluid in the lung, but why have I got fluid in the lung? Because the capillary pressure is what? The capillary pressure is greater than 20. Well, how did it get to be greater than 20? Well, because it was greater than 20 in my interlobular septi. Why was it greater in my interlobular septi? Because it was greater in my left atrium. And why was it greater in my left atrium? Because it was increased in my left ventricle. Oh, and I've made the definition, haven't I? An increase in left ventricular and diastolic pressure is a marker of failure. Pulmonary edema means That pressure has backed up all the way through the tree to give me edema. So it's not that the crackles are diagnostic, it's that the crackles prove pressure. Okay, what else do I look at with my stethoscope in congestive heart failure? I want two things. One's crackles. What's my other? What's an S3? It is an added sound. Kentucky, Kentucky, Kentucky. But why? Why? An S3 is anytime you have an atrium kicking into an increased or dilated left ventricle, right? So it's an atrial sound into a wide open or dilated ventricle. So why does a dilated ventricle mark congestive heart failure? Because it's a marker of, well, remodeling, right? So when you do your physical exam, you're not memorizing words, you're testing for pathophys. Do you see that? So when I say crackles in S3, it's because I've got this universal picture in my head. Okay, let's try something else. I'm going to give you a chest x-ray. What can we see on chest x-ray that would prove congestive heart failure? The first is going to be cardiomegaly. Why does cardiomegaly prove congestive heart failure? When this is greater than 50% the width, because cardiomegaly is evidence of LVH, that's fine. But what's that a marker of, NIDA? It's a marker of remodeling. It's a marker of remodeling. Part of the pathophysiology of heart failure. Okay, can you see pulmonary edema on a chest x-ray? Sure can. So when you see this edema, right, so you see perihilar edema. And edema is a marker because greater than 20, all the way back. Okay, and it's not called opacity, it's called consolidation. I'm going to give you a single blood test. What single blood test would prove it? What single blood test would prove congestive heart failure? Well, come on, you interns, you've ordered it a million times. The test is a BNP. Why does a BNP prove heart failure? How does a BNP prove heart failure? Because remember, your cardiac myocytes have stress response. So if I was in my atria here, in my right atrium, when I have an increase in end diastolic volume, what does it release? What does my right atrium release? Have I lost everyone? I'm not seeing any answers. Is everyone still there? Oh, yeah. Okay, good, Solani. Right. So that is ANP, and that's physiologic. But over here in the ventricle, it is BNP, and it is pathologic. So BNP equals increased ventricular and diastolic pressure. And there's lots of other things we can do with this diagram. We can talk about symptoms in this diagram. We can talk about echo in this diagram. But this is the universal picture. And you can see now as you go through your courses, what have you got to be able to take out of each of your courses? Well, look at, here's how we're doing structure and function. You got to be able to do anatomy. When I come here, here's your physiology. Here's your pathology. The only thing you're left with is pharmacology. And if you take a look, all of my pharmacology is basically blocking my neurohormonal. So when you get back to me at the end, and I'm going to absolutely give you a congestive heart failure, I will expect you to be able to tell me, draw me a heart, show me how the body monitors its volume pressure, tell me how it neurohormonally changes that, all the way down to the cellular level. So you're going to have to be able to draw me a beta-1 receptor and show me what it does in the myocyte. And then when that's not enough, you're going to have to be able to come over and show me the pathology. And then when we get to the pathology, each of these has a picture as a way of thinking about them. So as you go forward and you're learning from all of your courses, trust me, I'm waiting at the end. And waiting at the end is going to be the patient. So when you come and take our course, remember the things that we're going to be learning, right? Patient-centered learning. Every time you see a disease, in your mind say, who's going to walk in the door? When would I think about this? Remember that if clinical medicine is built on basic sciences, learn the basic sciences that underpin patient care. There's lots of really boring people out there. We've got this little meme that's Dr. Rubish's, right? Hashtag MMC. Every time someone teaches you a fact, how do I use that in patient care? Every time there's a diagnosis, right? Presentation, pathophys, natural history. Symptoms, exam, testing, right? They come out of the pathophysiologic picture that you have here. Every disease, I want you to draw me the picture and tell me the story. And then for natural history, remember, you're going to sit down with your patient and say, what does this mean to me, doctor, right? So you've got to talk about prognosis. You got to do complications. And you notice treatment isn't just drugs. You're treating patients. So it might be surgery. It might be radiation. It might be watchful waiting. So pharmacology is certainly really important. But we're doctors. We do all of the therapeutics, and your exam is going to reflect that.